Well, thanks for your introduction. And I have to thank the organizing committee for inviting me here. Though I must say, you provided me with kind of a difficult title, which for one, I'm not even able to pronounce. And I'm not going to give it a try even. But then also training. Yeah, what is training? Is it this kind of a 2-day thing, or is it more like a lifelong endeavor? And excellence, what do you mean by excellence? Can we measure that? And a difficult word, well, it's difficult enough. I'm afraid I, like the previous speakers, don't have all the answers on the difficult topics the different topics we are addressing, but I'll take you along to some of the developments in medical education as we are working to come a bit farther in this field. To start with, no conflicts of interest. And then this looks like a nice definition, so we know what we're talking about. Run to sick patients, while most others run away from them. This is from Scott Weingart, who is an emergency physician from New York, and is the editor-in-chief of this very interesting blog on emergency medicine, which is really something to take some time and study it. A resuscitationist can be anybody, a cardiologist perhaps, a nurse in the ICU, an anesthetist, ambulance nurse, or perhaps even a nurse or a junior doctor in a general ward. But this is what it is about. And we heard this morning already a lot about the unfortunate fall of Luke Smith, be it cardiac arrest or neurotrauma or whatever. And you really want those on the scene, in the ambulance, in a hospital, to have the best training available, to be up and running, to do their jobs, to do their tasks, for whatever is necessary. But how then do you provide them with this training? Well, for one thing, they need, of course, knowledge. Knowledge on causes of cardiac arrest. Knowledge on all kinds of medication. Knowledge on indications to start resuscitation, but also reasons to refrain from further efforts. Skills. Put in a tube, put in a line, put in another line, and a third line, do volume resuscitation, perform compressions of the thorax. And attitude. When you participate in resuscitation, it's always a team effort, as was addressed this morning also. And so you have to be part of the team, so collaborate. Listen, speak up, be a leader, but also be a follower when needed. And be willing to run to your patient when necessary. And nowadays we like to all take this together and say resuscitation is actually an EPA, an Entrustable professional activity. What's that? The phrase was coined by Professor Ten Kate already almost 15 years ago. An EPA is an identifiable part of the clinical work in your local context. It's part of work. It requires knowledge, skills, and attitudes. So different competencies come together in an EPA. Part of the regular work. So for an anesthetist in training, taking care of a multiple trauma patient might well be an EPA. But taking care of anesthesia in cardiac transplant patients would not be considered a normal EPA in training of an anesthetist. Regular work. Several items from the Cameron framework performed separately from other tasks because it's a task you entrust. I entrust you to do this part of the clinical work, or I won't entrust you to do this. Execute within a limited time frame, so doing your PhD would not be considered a good EPA for most normal people at least, and be observed and obsessed. I'll give you an example. Knowledge, skills, and attitudes, different competencies. Here are a few when we're talking about resuscitation. Know your medication, put your IV line in, perform mask ventilation, etc. And of competencies, there are really a lot. If we look at the training program for anesthesia, the anesthesia residency 5-year program used to have a total of about 600 competencies, which is, of course, far too large a number for us ever to be able to assess it, to know how we're actually going to train this. And also in resuscitation. So these are a couple of the competencies involved, but there are, of course, a lot more. And what we would say is, you have an EPA. And this EPA is called Assessment and Treatment of a Patient in a Resuscitation Situation. And a lot of competencies are involved in this EPA, of course. For each EPA, you have competencies from the different competency fields. You recognize the chemist's flower, even if there's no flower depicted here. And by focusing your assessment on the EPA, you implicitly know something about the competencies involved. So we don't try to measure how your performance is in those tens or hundreds of competencies. We see how you're doing in this EPA and then look what is going well and what should be improved. And for the last couple of years, 2-3 years, almost all residency programs in the Netherlands have built their programs on EPAs. And for example, in anesthesia, we now have a new program which starts within a couple of months, where you have 30 EPAs in a 5-year program. And a new program for emergency medicine in the Netherlands, a 3-year program, has 19 EPAs. So those are workable numbers. Entrustable professional activity. The trust part is important. Well, I'm not quite sure about the trust here. It's developing. And while we're not very good in assessing all those different competencies, working with a student or resident as a faculty member will provide you quite easily with an idea of her performance and whether or not you will let her perform this task with indirect supervision. When you're on call and as a resident, you have to take care of, who's under your supervision, you have to make these decisions of entrustment numerous times. There will be a new patient in the emergency department. Will I let her go there on her own? Or will I come along and see how she's doing? If I go along, will I stay on the side and just watch? Or will I be there at the side of the patient? Or will I take over? And in assessing EPAs, we use predefined supervision levels as a measure for the actual performance of the student or the resident. And trust is important. When someone can be trusted and feels that she can be trusted, it will be an enormous boost to her feeling of autonomy. It will help her increase her level of competence, and it will increase the feeling of belonging to the team, to relatedness. And autonomy, relatedness, and competency all leads to an increase in intrinsic motivation, and that will lead to better learning and better outcome. But we trust, we like to trust, but it's also nice to check some things. So we use a long list of assessment tools, formative as well as summative, to see how your student, how your resident is doing at the workplace. Suppose you are a fifth-year medical student and you're wondering, to be or not to be, whether a career in some discipline related to emergency medicine might be something for you. You might just consider. How are you going to make your choice? If you did not have a longer rotation in this field, how can you be sure that you are suited for a job in this field? That the program directors will take you along. End of medical school is in this regard a difficult phase. The last year of the medical training program is meant to help with this transition, going from a role as medical student to your role as junior doctor, a junior doctor to whom clinical tasks can be entrusted, to whom taking care of this sick patient can be entrusted. And in most universities in the Netherlands, as a student, you're free to choose electives in this last year to see what suits you and where you feel comfortable in what field of medicine. In Utrecht now, for 4 years, we have a multidisciplinary program, which we call the dedicated transitional year acute care, vitale functies in Dutch, but that you can't translate that in English. So acute care, which is meant to help students get experience in this field of emergency medicine without having to choose for one specific discipline, because you do not know yet in that phase whether it will actually suit you. This is how the transitional year is built up, with mainly 3 clinical electives and a research elective, which all have to be chosen from a small group of specialties. It's anesthesia, emergency medicine, cardiology, pulmonary medicine, and ICU. And you can't choose 3 clinical electives in the same field, you have to choose different ones. And we built a learning community. So we provide these students, and it's an elective, so we have about 25 students each year that choose to do this dedicated transitional year. We get them together and provide them with monthly training where only those students are allowed. And we address issues in the field of emergency medicine. We provide them with a mentor, and a mentor is a senior resident from one of the fields they have chosen their elective in. This mentor has no role in the system. It is just for the student that she has someone to address, to discuss how to make your choices. How can you combine this work with raising a family? What is the right moment to address this program director? What should I do when I feel these doubts? And we built the dedicated transitional year around 3 EPAs. Actually, that we used EPAs to bring the specialties together, to see that there are things which are important to all of these involved disciplines. Whether you end up as an anesthetist or an emergency physician or as a cardiologist, in the EPAs involved in the dedicated transitional year, you will learn the things that will make transition more easy. No specialty-specific EPAs. There's no EPA on anesthesia, no EPA on cardiology. And all have a focus on acute care, of course. These are 3 EPAs. Evaluation and initial treatment of a patient with compromised circulation, of the ventilation, or threatened vital functions of a patient in the emergency department. So the students learn to work with these situations and learn to handle themselves And we're talking about circulation, it might be allergic reactions, it might be talking about blood loss, you might be talking here about cardiac failure. And whether you enter as a pulmonologist or a cardiologist or an anesthetist, you all have to learn about these things. This year, dedicated transitional year, is not only about these EPAs, it's not only about acute care. Of course, you have to develop into the role of a junior doctor, but the focus is here. Well then, training. Yeah, how do you do training? Training in resuscitation. Well, we know that already, don't we? You train, simulate the situations, you train as a team, and you train again, and you train again, and the more often you do this, the better you will be. I just read an article last week, I must say, I forgot who the authors were, but showing that when you do resuscitation training, this was about the basic skills, on a monthly basis, you are actually better than when you do it on a half-yearly basis or a yearly basis. Not really surprising, and perhaps a bit impractical, because who finds the time to do this? But of course, training helps, and repeating training helps, and working and training of a team helps. The better you do that, the better you will work as a team in the clinical situation. But then you really have to take your student to the actual life situation, or put it, the resuscitation situation. Involve your student, be it a medical student, a nursing student, a resident from a different discipline. By giving them an active role in this procedure, you will give an enormous boost to their sense of belonging. They will be part of the team. And of course, you have to take good care of them. You can't ask them to do things where they're not trained to do. But you can take it one step further. And by being involved in the actual process, you will increase their motivation enormously. If someone at the picture resembles someone in the audience here, that is of course a coincidence. And then, all day we've heard things about heroic measures to save patients. And it's good. And it's also part of the story. Because resuscitation is also about failure. It's about despair. Of family members, but also of members of your team. So you have to address these issues. And when you speak with a family, telling them their loved one is going to die, or ask them for organ donation, you have to have the students involved. Don't send them away and say, well, this is way too difficult for you, or this is over your head. You cannot be involved here. This is also part of resuscitation, and this is also part of training. And when we're talking about training and education, this is most important. It is all about feedback. Whatever you do, be it in the simulation center or an actual life situation in your hospital, wherever, take the time to provide the student with feedback. Stimulate reflection, because reflection is the only way someone is able to learn. It's true for the students, it's true for you. You reflect on what you heard, reflect on what's been told, reflect on what you've seen, reflect from your failures, and reflect on what has went good, and provide you with a happy family afterwards. take time for feedback and stimulate reflection. And to get back to trust. Trust is on the basis to help your student come to autonomy. And sometimes you have to push the student one bit further. All right. Thanks for your attention.